chief guests, myself Dr. Vishnukant Munde, Associate Professor, Department of Shalyatantra, Dhanvantari Ayurved Medical College and Hospital Udgir, welcomes all of you in this today's webinar. बाळ भगवान शिक्षण प्रसारक मंडळ अहमदपूर, धन्वंतरी आयुर्वेद मेडिकल कॉलेज and charitable hospital Udgir, district Latur, Department of Shalyatantra organizes national webinar on Ayurvedic management of anorectal disorders. This webinar is endorsed and affiliated by Maharashtra University of Health Sciences, Nashik, and Maharashtra Council of Indian Medicine, Mumbai. Organizing committee for this webinar series is our principal sir, Dr. Dattatray Patil, Dr. Namdev Bansode sir, Dr. Om Chitte sir, Dr. Namrata Kore madam, and Dr. Vishnukant Jadhav sir. Before starting our first session, we will pray our Lord Dhanvantari. I request Dr. Avinash Jadhav sir to play Dhanvantari Stavan.
शंखं चक्रं जलौकां दधतम् अमृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मा स्वच्छातिहृद्याञ्शुकपरिविलसन् मौलिमम्भोजनेत्रम् कालाम्भोदोज्ज्वलाङ्गम् कटितट विलसत् चारुपीताम्बराढ्यम् वन्दे धन्वन्तरीं निखिल गदबल प्रौढदावाग्निलीलम् रागादिरोगान् सततानुशक्तान् अशेषकाय प्रसृतानशेषान् औत्सुक्यमोहारतिदाञ्जघान यो पूर्ववैद्याय नमोऽस्तु तस्मै नमोऽस्तु तस्मै नमोऽस्तु तस्मै नमोऽस्तु तस्मै.
Thank you, Dr. Avinash sir. Now we will proceed towards our first session of this webinar. Dr. Yogesh Turner sir will coordinate this first session. I request Dr. Yogesh sir to continue.
Thank you, Dr. Vishnukant Munde sir. Good morning to all. Firstly, I introduce myself. I am Dr. Yogeshwar Namdev Surner, Assistant Professor in Shalyatantra Department at Dhanvantari Ayurved Medical College, Udgir. Now we are going to start our first session of today's webinar. For this session, we have eminent speaker, Honorable Dr. Rahul Baviskar sir. He is a professor and HOD of Shalyatantra Department in Srimati K.C. Ajmera Ayurved College, Devpur, Dhule. For this first session, we have chairperson, Honorable Dr. Sanjeev Yadav sir. He is a principal at YMT Ayurved College, Kharghar, Navi Mumbai. And Honorable Dr. Kalpana Pandre ma'am, she is Associate Professor in Shalyatantra Department at SGR Ayurved College, Solapur. The topic of this session is role of Ayurveda in fishery nano. Before starting speech, I will give a brief introduction of Dr. Rahul Baviskar sir. Dr. Rahul Himmatrao Baviskar sir is presently working as a professor and HOD, Department of Shalyatantra in Srimati K.C. Ajmera Ayurved College, Devpur, Dhule, and as a surgeon at Chaitanya Multispeciality Hospital, Devpur. He obtained his MS degree from Vidarbha Ayurved Mahavidyalaya, Amravati, and PhD in Shalyatantra from R.A. Poddar Ayurved Medical College, Mumbai. His teaching experience is about 16 years. He received 3 awards. First one is Guruvarya Trey M. Gopte Smurti Puraskar 2021 in teaching category. Second one is Patriots in White 2020 for the care and services provided to the mankind during the COVID-19 pandemic by Time of India Group. And third one is Nation Builder Award 2021 for the valuable contribution in nation building as a teacher, given by Rotary Club Dhule. He has published near about 9 research papers. He attended more than 20 national and international seminars. He has performed approx 4,000 major and minor operative independently after completion of MS. His area of expertise includes leech therapy, rectomoction, leech reproduction, that is breeding, anorectal surgery, nadi chikitsa through Ayurveda. Now I request to Dr. Rahul Baviskar sir to start his speech. Please, Dr. Rahul Baviskar sir.
Good morning, all respected teachers and faculties. First of all, I want to thank Dr. Datta Patil sir, Principal, Ayurvedic College, Udgir, for giving me opportunity to deliver this lecture. I also thankful to all the organizing team of this webinar for giving this opportunity and the nice arrangement they have made here. Sir, sir, is the PPT visible?
Yes, sir.
Yes. First of all, bowing to the Lord Dhanvantari, myself, Dr. Rahul Baviskar. Today's topic of lecture is role of Ayurveda in the management of fissure in ano. The pain is more terrible lord of mankind than even the death itself. This has been quoted by Albert Schweitzer. The God has bestowed mankind with the best of his gifts and made man the supremest creator of the universe. But there are a few drawbacks that human race carries with themselves from their ancestors and to their progeny. One such drawback, one such black spot of mankind are the diseases of anus and rectum. Current surgery has made enormous progress in branches like neurosurgery and microscopic endoscopic surgeries. There is also biomedical engineering has advanced in diagnostic and management techniques, but certain diseases like anorectal diseases seems to mock this progress achieved by the mankind. So these anorectal diseases demand innovative, logical, and in-depth thinking in each patient for their management. So let's see why this is so. The word Guda used by acharyas to denote the organ that performs the actual function of defecation. Acharya Sushruta has given a detailed description of embryology development of Guda in Sharirsthanam. Sushruta is also known for the technique of dissection. Thus, after detailed studies, he has also mentioned about the blood supply, nerve supply, musculature, and also functioning of the Guda in detail there. So the Utpatti of Guda, it is a word of masculine gender. Godet means to play. The word Guda is at times used for both, that is, end part of the digestive system or end part of the urogenital system. Thus, the chief site of the Apan Vayu is a Guda, as described by Sushruta. The importance of Guda, why there is so much importance has been given. The Acharyas has opened that the Guda is a Sadhya Pranahar Marma. The trauma or insult to it causes instantaneous death. That we all who are practicing in anorectal or who are handling anorectal cases, they must have came across such a things when patient goes in vasovagal shock after just doing PR or after just examination. This has injury to this causes obstruction of the Apan Vayu, flatus, mala, feces, and loss of movement in stoolantra, that is paralytic ileus also, and the patient dies instantly. This can be seen in vasovagal shocks by when patient feels extreme pain at anal region. Parigartika, Utpatti of Parigartika. The word pari, when it is used when a suffix, it means all over, whole, or every entity, or every aspect. Kartika is derived from krita, the word which means to cut. It is noun form. Thus, the word parikarta as a whole means to cut circumferentially or to cut all around. The Nirukti, each and every acharya has described its Nirukti. Kashyapa says that the one having cutting and tearing of pen. Jejeta has anticipated about the condition and opened in a very pinpointed way according to him. This means specific vatic pain is present all around in specific area of good. It is parikartika. According to Dallana, the commentator of Sutrut Samhita, there is cutting and tearing pain everyone. Fisher, this term, according to modern, Fisher, this terms been derived from a Latin root, that is fissura. That means a cleft, sulk, or a groove, normal or otherwise. Fissure in ano is a true ulcer in a anodon. Epidemiology, young or middle-aged adults, 30 to 50 years, especially women, suffer from the fissure the most. Occasionally in infancy or early childhood, resulting in acquired megacolon, uncommon in age group. The cause may be laxity of the muscle. Sex. Fissure in ano common in women than in men. Anterior fissure is more common in women than in men. The ratio of incontinence, incidence of anterior fissure in ano to the posterior fissure in ano in women is about 40:60, and that in men is 10:90. Condition is more common in women than in women in the meridian of their life site. The most common site is midline posteriorly. Next frequent site is midline anterior. Other sites are also not very uncommon, but when anal ulcers are more in number, one most suspect associated diseases like tuberculosis, septic, ulcerative colitis, etc.
Please change the slides, sir.
Sir, slides are not changing. Can you reshare the screen?
Okay, sir. Okay. If it is visible now?
Yes.
Yes, sir. Yes, sir. Epidemiology slide.
Okay. Etiology. Because of the site, Guda, which is actual site of Vata, especially upon Vayu. Also the kind of pain and other symptoms of the condition point towards the visheshan of Vata. Tikna, Ushna, Kashay, Alpabodhan, Vegdharan, Udiran, Vegudiran, excessive Shodhan, therapy, diurnal and seasonal variation. These are the common causes which leads to visheshan of Vata dosha. And there are another causes of fissure in ano. These are rog nimittas, means that is the secondary causes, and the vaidya nimittas, that is idiopathic causes or iatrogenic causes, vaidya nimittas. The main cause of fissure in ano is a trauma, mainly due to passage of large constipated fecal matter and over distending of the anal canal. The fibers of the sphincter ani external decussate on their way to get attached to the coccyx, leaving a weak spot in a posterior midline. So posterior midline is more common site for fissure in ano. In a region that habitually takes laxative and purgatives or has irritable colon, suffers from absence of normal stretchability of the sphincters when this condition persists for many years. It results in fibrous contractures of the sphincters. In such a condition, a tear easily occurs when a hard mass is passed while straining during the defecation. Other reasons include tear by a foreign body like a piece of glass or bone, or other iatrogenic insertions of overlarge speculum or a proctoscope, or one with rough surfaces or instruments which are having rough surfaces are among some of the rare causes. Constipation has been the most common etiological factor. Spasm of the internal sphincter has also been incriminated to cause fissure in ano. When too much skin has been removed during operations for hemorrhoids, anal stenosis may result in which anal fissure may develop when hard motion passes through the such strictures. Secondary causes of anal fissures must be remembered, and these are ulcerative colitis, Crohn's disease, syphilis, tuberculosis. So, in short, the causes or fissures can be divided into primary and secondary. Primary in this idiopathic type of fissure, there is no pre-existing disease or any other cause except constipation. And secondary fissures are such fissures can further be classified as complication of other diseases or post-operative or condition to which fissures may where secondary are non-specific. These are proctocolitis, Crohn's disease, syphilis, tuberculosis, etc. Then the signs and symptoms. Acute fissure in ano. Everybody knows what are the signs and symptoms. The acute fissure in ano is a tear of skin of a lower half of the anal canal. There is hardly any inflammatory induration or edema of the edges. Anal sphincter's muscle spasm is always present. Chronic fissure in ano. If the acute fissure fails to heal, it will gradually develop into a deep undermined ulcers, termed now as a chronic fissure. It is a deep canoe-shaped ulcer which with thick edematous margins. At the upper end of the ulcer, there is hypertrophied papilla. At the lower end of the ulcer, there is skin tag known as sentinel pile. There is characteristics, inflammation, and induration at the margins. Base consists of scar tissue and intersphincteric muscles. The spasm of the internal sphincter is always present. Sometimes infection may lead to abscess formation also here. Chronic fissure in ano may have a specific cause, for example, Crohn's disease, ulcerative colitis, tuberculosis, syphilis, so they should be elicited or differentiated. In long-standing cases, the muscles becomes organically contracted by infiltration of fibrous tissue. The situation of the fissure in ano in the vertical axis of the anal canal is very constant. It and in the cutaneous portion of the anal lining between the level of the anal walls and the anal orifice. In this position, it is situated to the lowermost quarter of the third of the internal sphincter muscle. Clinical features. These are the common pain on the defecation. Then bright red bleeding. This is usually a fresh bleed, and it is usually not in a huge amount. Usually streak of blood on the fecal matter only. There might be some mucus discharge, little one, and the constipation. There may be some associated symptoms also. Because of the discharge, there may be mild pruritus also. There might be some urinary symptoms. The pain is so intense in acute or chronic fissure that patient sometimes avoids going to defecation. This may also indulge or in this may also give rise to urinary symptoms like uh, uh, that is pain at the time of micturition. There may be complete retention also. Then there are some secondary changes. This secondary Sir, excuse me.
Sir.
Screen sharing has stopped because of some reasons. I will just correct it with.
Okay, okay, sir.
Okay, just give me 2 minutes.
Okay, sir. Sir, screen is visible. Please unmute yourself.
Is the screen is visible now?
Yes, sir.
Okay. Sorry for the disturbance. There are some secondary changes. There is a sentinel pine. Sentinel pine is swelling of a skin at the lower end of the fissure. Actually, at the level of anal orifice is of the most striking feature. It forms a tag-like swelling. The so-called and the called is sentinel pile. This is presumably due to the low-grade infection and lymphatic edema, and often the tag has very inflamed, tense, and edematous appearance. Later, it may undergo fibrosis and persist as a permanent fibrous skin tag soon after fissure has healed. The patient may come with associated complaints of an irreducible tender mass protruding near the anus. It may cause difficulty in walking or sitting when edematous, or may be asymptomatic when fibrous. At the inner end of the fissure, similar etiopathogenesis appears and gives result to a hypertrophied papilla of the anal mucosa. It is a pyramidal in shape and is tender on touch. Due to constant spasm of the internal sphincter muscle due to pain, there is a gradual fibrosis of the muscle, and there is a strict stricture of the anal orifice. Then what are the complications that may appear here? These are the commonest complication which appears is a fissure infection in a fissure which lead to fissure abscess. Later, it may also give rise to a fistula in ano. Just remember the term where Sushruta has mentioned one such condition. It is Arshobagandhar, that is fissure fistula complex. Then another complication is sentinel tag, enlarged papilla, and anal constricture. These are the complications of fissure in ano. Then for the students' purpose, I'm just mentioning few examination points that students should remember while going for examination of fissure in ano or anorectal case. These are the history, namesakes, age, chief complaints. Then the chief complaints of fissure in ano are bleeding. Amount usually is very less. Presentation of bleeding is streak-wise or drop-wise. Color of blood is usually bright red. Its relation to defecation, it is during and after the defecation. Discharge of mucus sometimes may be present in case of chronic anal fissure. Quantity is very less and may just cause a little amount of itching or wet sensation immediately after around the anus. Then pain, all pathologies below the Hilton lines are very painful. Nature of pain is a sharp cutting agonizing pain with burning sensation. Relation with defecation, during and after defecation for few minutes to several hours and disappearing suddenly. Abnormality of bowel habits. Usually frequency is reduced to once a day or in days together. Consistency is usually hard, picolate type of cable. Constipation, mainly it is due to the pain that patient avoids the act of defecation. Shape of bowel, it may become tape-like in chronic fissure in ano case due to fibrosis and stricture. Protrusion of mass. Consistency, it is skin tag that is usually soft in consistency, but it may become firm when inflamed and swollen. Size may vary from few millimeters to centimeters. Irreducibility, patient may complain of protruding mass that remains out constantly. Past history, habitual constipation is usually present in most of the cases of fissure in ano. Family history, it may be positive due to similarity of food material or daily routines or diet habits. Personal history, stress that Stress that may be physical or mental does play an important role in production and recurrence of fissure in anal. Examination of anal case. The coach should be of sufficient height to allow lady inspection and access for a necessary maneuvers. There should be a good light. Then position. There are various positions which uh, student can go with, but like Sims position, dorsal position, knee elbow position, right lateral position. But the most suitable position is lithotomy position. This is the most advantageous position since it gives a gives very easy access to the perianal skin during inspection. It also helps in palpation since the anal orifice is nicely exposed, and when very little effort can one can examine a case of fissure by just incision. Lesion. There is inflammatory skin changes. Ask the patient to strain down before inspection is completed and anal margins are separated manually very gently with proper aseptic measures. Sentinel pile is most probably situated in the midline posteriorly. Then palpation. Palpation of the perianal skin should be performed gently to eliminate other pathologies like fistulous tracts or tumors. An inflamed tag will be a tender on palpation. A spasm sphincter is strongly suggestive of acute fissure in ano. Digital examination. Always remember, students, please always remember one thing. Digital examination in presence of any painful anorectal condition is usually contraindicated. But with good lubrication, proper glowing of the hands, and with good anesthesia by local this digital examination can be done, but it should always be remembered we should not indulge in giving pain to the patient. It should be carried out under good anesthesia only. A few quiet words means you have to assure patient that we will not import you too much pain while doing this digital examination. Findings: intraluminal per rectal digital examination under anesthesia or local anesthesia or saddle anesthesia or spinal anesthesia. The findings may be normal pieces, abnormal, there may be a polyp or some mass there may be. Intramural sphincter muscles and anorectal angle should be examined. Extramural perianal structure should be examined. Fibrous edges of the ulcers and tenderness on the site with discharge. Papilloma that has to be examined. Discharge after withdrawal of the finger. Mucus, pus, blood, abnormal fecal matter that has to be examined. Then proctoscopy. Again the same thing. Proctoscopy should be avoided in cases of fissure in ano. But if your patient is under anesthesia, you can go for proctoscopy. In case of fissure, this examination is very painful and should only be performed if felt inevitable under the local anesthesia, not local anesthesia, but the spinal anesthesia only. Parts under vision: lower third of the rectum with mucosa to eliminate associated pathologies like piles, ulcerative colitis, proctitis, etc. Patient should be instructed to strain during withdrawal to notify internal intussusceptions. Then we came towards the differential diagnosis. Just seeing a ulcer and labeling it as a fissure in ano is not always possible. We should also keep in mind some other diseases to differentiate this fissure in ano, that pruritus ano. Pruritus ano, there may be multiple fissures because of this pruritus ano. Patient may scratch his perianal skin or there might giving rise to multiple fissures. then ulcerative colitis, Crohn's disease, squamous cell carcinoma of adenocarcinoma of the rectum invading the anal canal, syphilitic fissures, tubercular ulcers, idiopathic stenosis of the internal. These are all the conditions that we should rule out before going for the treatment. Then the treatment of pericardica. Pericardica as a disease has been considered very tightly by the Sushruta and other successive authors. They have described the treatment of pericarditis in most brief manner. Kashyapa has mentioned its management according to doshic type, that is Vatic, Pittis, and Kapik also. But in true, that none of them has described surgical management, thereby showing that there was no need of surgery at the as a disease was completely cured by the use of medicinal preparations only, and they were satisfied with the management. In Ayurvedic literature, there is no surgery has been advocated. The treatments, these Ayurvedic treatments usually includes two types of basti described by Susruta and other Ayurvedic, that is Anvasan basti, Picha basti, and Sital basti. Mainly, they use Kashaya rasa, Shitavirya drugs, and Madhur rasa drugs. In general treatment, the oral preparations have manifold objectives. Some drugs are used to correct the gastrointestinal disorders. Others are used as laxative. Few more to increase the digestive. That is all Dipan and Patan Dravyat, and some Anulomak Dravyat. They have advised drugs as the Tridosh Shamak drugs. And the third treatment is surgery. This is the treatment advocated by Kashyapa, that is Vatik Parikartika, Brahmi, Bel, Anant are used, which have the Vat Shamak properties. Pittas Parikartika, Madhu and Kapas Parikartika. There are so many drugs they have advised. All the treatments are based on following factors. One, to elevate the Vata and Pitta, and to correct the abdominal trouble because of this disease, Vata and Pitta are these. Most of the patients come with burning type of pain. So keeping these points in the mind, all Ayurvedic authors have described only Vata and Pitta Shamak management mostly. So coming to actual treatment, where in which cases we should go for conservative treatment and in which patients we go for surgical treatment. When fissure is of short and single history of pain, we should go for conservative treatment. There is no sentinel tag, no induration in the edges, scar is superficial, fibers of internal sphincter are not exposed, mild to moderate pain. Then the conditions where we should go for surgical treatment, long and continuous or intermittent history of pain, large sentinel tag, induration in the edges of fissure present when the fissure is too deep, fissures of internal sphincters, fibers of internal sphincters are exposed, severe pain in acute or chronic cases of fissure in ano. This is the sort basis on which we should select conservative treatment or surgical treatment. Conservative treatment, avoidance of constipation. There are so many. There are different types of laxatives which are available according to modern and according to Ayurveda also. Then there are some anesthetic ointments and anal dilator. There are some local anesthetic agents also which give pain relief, analgesics and muscle relaxants, and application of glyceryl trinitrate. Surgery, stretching of anal sphincters, that is Lord anal dilatation. It is very simple to perform. Even our junior the PG students can also perform such a simple procedure. Then excision of anal fissure, with immediate skin grafting and division of internal sphincter. So the role of Ayurveda in fissure in ano, going through the causes and the types of fissure, that acute fissure in ano and chronic fissure in ano, there are certain things that we should keep in mind for relieving the cause, that is nidan parivarjan, the constipation. The the best treatment we can find found in Ayurveda only. There are different types of laxative. There are some Anuloma, Virecha, Veda. There are different types. These are described by various acharyas. We should select uh, laxatives according to the type of constipation that patient is having, or type of patient that is crude constipations, that patient should be treated likewise, that is strong laxative. But the most of the time anulomak dravyas that are sufficient for uh, laxative purpose. But other things that Ayurveda can work in fishery nano is the ropan dravyas that we have. That there are good ropan qualities. That so many there are so many drugs which are having ropan qualities, and which like जात्यादी तेल, जात्यादी घृत, यष्टिमधु सिद्ध घृत. यष्टिमधु सिद्ध घृत having a multifocal action. Yष्टिमधु, as we all know, is having some steroidal action also. So yष्टिमधु सिद्ध घृत is helps in healing of the fishery nano. It helps in reduction in pain. It also helps in the edema, which is slight amount of edema which is present around the fishery nano. It is the best thing for the local application to use in case of fishery nano. Another thing, the spasm, which is very more important in case of fishery nano. Once there is a spasm, there is always a pain. If you relieve the spasm, there is definitely reduction in the pain. And to relieve the spasm of the sphincters, we can go for that is avgaha sweat, or what we call is that a sits bath. Sits bath gives a little bit or good amount of muscle relaxation, and once the muscles are relaxed, there is definitely there is a pain relieving action is there. So with all these words, I conclude my session. I once again thanks to all the organizers, especially Dr. Datta Patil sir, the whole team of Udgir Ayurved Medical College of organizing this seminar. I also thankful to all the listeners. I also thankful to Chairman Dr. Yadav sir and Madam Co-Chairman. Thank you.
Thank you, sir, for such a wonderful speech on role of Ayurveda in fishery nano. This speech will surely add knowledge and update about Ayurveda and fishery nano. Now I request some comments on this speech from chairpersons. I request Dr. Sanjeev Yadav sir to comment on this session.
Hello, can you listen me? Hello, hello.
Yes, sir.
आवाज आ
Sir,
रही है?
you are audible.
Yes, sir. You are.
Yes. Good morning, everyone. Doctor, I am first of all, I am very thankful to entire organization and Honorable Dr. Datta Patil sir, Principal Anorectal Medical College, Udgir. Today's session, Dr. Bhaviskar has very nicely elaborate, complete and entire subject. This is very practically, clinically and academically, it is very important topic. In our day-to-day practice, we daily come across to these conditions, anorectal condition. And he has explained very nicely physiopathology, causes management, people management, conservative management, and all these things very nicely. I'm also proud for this thing. This is very clinical and academically topic for the students of Ayurveda. And I congratulates to Dr. Bhavister for his nice explanation, and I'm also congratulates to the entire team of organizing team of Anorectal Ayurvedic Medical College for this critical webinar. Thank you so much.
Thank you, sir. Thank you.
Thank you, sir. Now I request Dr. Kalpana Pandre ma'am to comment on this session.
Good morning, all. Firstly, thanks to Principal Dr. Datta Patil sir for selected me as a chairperson for this session. Very good initiative taken by college and the team of Shalya Tantra, and a very nice and fruitful session delivered by Dr. Rahul Baviskar sir. It is very useful to students and practitioners. Sir nicely told the indication for surgical and conservative treatment for fishery nano, and very good indications are there. So the students will take such decision which patient is selected for conservative treatment and which is selected for the surgical management. Very nice lecture, sir. Congratulations for this session. And
Thank you,
all
madam.
the for the next session. Thank you.
Thank you, ma'am. If anyone from the delegates wants to ask question, can ask now.
Dr. Rahul Bavaskar sir, there are some questions from audience. Hello, sir. Sir, you are audible?
Yes, sir. Yes, sir.
Yes, sir. Sir, one question is that how to manage pain in fishery nano with Ayurvedic treatment?
Sir, first of all, what I practice or follow with my patients, the first line of treatment in fishery nano, though there are 4 to 5 remedies that we can offer to the patients. First and the first thing is go for hot seats bath. That is the first remedy I advise to the patients. Hot seats bath definitely definitely reduces the pain. Second thing, most of the time because of the pain, this is the practical experience we we got. Patients, there are particles of fecal matter that remains inside the fissure or at the bed of the fissure. So once you go for hot seats bath, this fecal matter gets removed. Or if not, patient while applying local xylocaine jelly, patient should apply inside the anal canal, palpating the fissure bed. This will remove the foreign body or the that fecal particles of fecal matter that irritates fissure bed and gives more pain. Our practical experience is that once these particles are removed, pain stops immediately most of the times. As the the fecal matter contains substances which are similar to or similar to what in local language to explain patient I used to say fecal matter contains substances like urea and salt, and once they are present in the fissure bed, it will give rise to more pain that you have to remove. The first remedy is hot seats bath, then second remedy is removal of this fecal matter particles or foreign bodies, and third remedy is uh, uh, third remedy is local suppositories of diclofenac sodium with paracetamol, or you can also add suppositories of tramadol. But remember one thing, all these maneuvers are again painful as there is a spasm. So you should these remedies should be done after hot seat bath, which will relieve some sort of spasm, and you will be able to insert suppositories under again with the application of xylocaine jelly along with. So these are the few things, few remedies, and then afterward comes injections and other things.
Thank you, sir. Second question is how to manage fishery nano in pregnancy and after delivery? Sir, your voice is not audible.
Okay, okay,
Yes,
okay.
sir.
In pregnancy and in post PNC period, there are different causes of constipations. These are hormonal changes, and another is weight of gravid uterus. So once these changes are gone, so the constipation got relieved, and patient may not need surgery. What happens? The hormones which are increased during the pregnancy and lactating period, they cause more and more absorption of water through the fecal matter, and this fecal matter gets hard, and due to this uh, hard fecal matter and pressure from the above gravid uterus, patient feel pains or patient gets fissure in ano. In such cases, only conservative treatment should be advocated, like insertion of local jatyadi tel or Yashtimodhu Siddha tel or Yashtimodhu tel before and after of defecation. It will lubricate, it will try to heal the fissures with its Ropan quality, hot seats bath, and simple anulomic laxative, or in modern also we can give emollient laxative or stool softener only, not purgatives. In remember always one thing, purgatives are not advisable in case of fissure in ano, not even in pregnancy. Here, solutions like liquid paraffin that has to be given, uh, and this will definitely solve the problems in pregnant woman or PNC period. We should not advise immediate surgery in PNC period or in even in pregnancy. This should be managed conservative only.
Thank you, sir. One more question, sir. Which common Ayurvedic laxatives or anulomak drugs can be used in fishery nano?
Uh, there are so many. That is starting from Haritaki, Abhairishta, Abhairishta again also giving uh, results like Deepan and Patal also. But commonly that I am following is the Panchasakara Churna, as there are it is a mild laxative. I because it has got different ways of action in Panchasakara. There is Lavan, as you we all know, Lavan increase absorbs the water. It pulls the water from intestine or colon in the fecal matter. Haritaki, Sandav, Sonamukhi. These are the different contents that is Panchasakar Churna is having, that I usually follow to offer the patients.
Thank you, sir. Sir, there some secondary causes of fishery nano like prawns and ulcerative colitis. Can
Yes,
we manage such cases with Ayurvedic management?
yes, there are some remedies for ulcerative colitis that we have done some cases, like uh, Panchamrit purpose. For systemic purpose, we used to give patient Panchamrit Parpati once twice a day. Along with Takrarista. Sometimes we used to give Takrabasti, but in Takrabasti, what we do, we add some metronidazole also, with takra and give this basti with a drip method that we follow in such cases when there are ulcerative colitis is there.
Sir, one more question from audience.
But we do not afraid to say that we also continue some modern treatment with this while giving this Ayurvedic treatment. We also continue some modern treatments like tablet mesocol, 1 BD.
Thank you, sir. One more question. Sir, one more question.
Yes.
Is there any role of Botox injection in fishery nano?
Sorry, I haven't used it. Some people use Botox, but I haven't any experience regarding Botox. I have not used it anytime. It is always a costly matter, no? Injection Botox
Yes,
cost,
thank you, sir.
and there are so many cheap remedies are available.
Yes, sir. Sir, Gandharva Haritki is one of the drug. Lot of doctors are using, Vaidyas are using. Is it good or it's working good?
Yes, it works good. It works good.
Yes. Thank you, sir.
Thank you, sir. Thank you. Thank you all of you for patience hearing.
Thank you, sir. Now we proceed towards second session of this webinar. Dr. Vishnukant Munde, sir, will coordinate this session. Dr. Munde, sir, please continue.
Thank you, Dr. Yogesh, sir. First of all, we confirm that Dudmal sir is joined or not. Sir,
Join Lalit, sir.
Hello.
Okay, okay. Thank you, sir. Thank you.
Good
Yes,
morning,
I
sir.
have joined.
Yes, sir. Yes. Thank you, sir. Thank you, Dr. Yogesh, sir. Now we are going to start our second session of today's webinar. For this session, we have eminent speaker, Dr. Dudmal, sir. Dr. Tukaram Dudmal, sir. He is professor, Institute of Teaching and Research in Ayurveda, Jamnagar. For this session, we have chairpersons, Dr. Manjusha Kalmek, madam, Professor, Vidarbha Ayurved Medical College, Amravati, and second chairperson, Dr. Rashmi Kale, madam, Professor, SSAM Ayurved College, Hadapsar, Pune. The topic for this session is role of Ayurveda in the diagnosis and management of fistula in ano. Before starting speech, I will give a brief introduction of Dr. Tukaram Dudmal, sir. Dr. Tukaram Sambhaji Dudmal, sir, is presently working as professor and in charge head of the Department of Shalya Tantra, Institute of Teaching and Research in Ayurveda, Jamnagar, Gujarat. He obtained his MS degree from Government Ayurved College, Nanded, and his PhD Shalya Tantra from Gujarat Ayurved University, Jamnagar. His teaching experience is 21 years. To PG and clinical experience is 24 years. He guided 29 PG and 12 PhD scholars. Presently, 9 PGs and 5 PhD students are doing research under his guidance. He received Best Teacher in 2021 by National Shushrut Association, India. He has been worked in many committees as committee member at institute and national level. He has been served as nodal officer of 100-bedded COVID care center, IPGT and RA Hospital, Jamnagar during the first and second wave of COVID-19 pandemic. There 3 books and 10 chapters of Ayurveda are in his credit. He has published more than 200 research articles in referral journals. He delivered more than 50 guest lectures in CMEs, national and international seminars, and attended more than 62 national and international seminars. He completed 5 research projects as a principal investigator, and 2 research projects are going on. He is working as a reviewer and subject editor in many scientific journals like AYU, AAM, JAIM, JRAS, etc. He visited to Tajikistan, Russia, Sri Lanka, China, Hungary with various responsibilities to deliver the lecture on Ayurveda, Kshar Sutra and wound healing. His area of expertise includes wound healing, Kshar Sutra, anorectal surgery, leech application, musculoskeletal disorders, and urinary disorders through Ayurveda. This is now I request Dr. Tukaram Dudhmal sir to start his speech. Dr. Tukaram Dudhmal sir, please start your session and speech.
Sir,
Dr.
please
Dudhmal,
unmute
sir.
yourself.
Hello. It is audible, sir?
Yes, sir, you are audible.
And slide is also visible, right?
Yes, sir, visible.
Okay. So, thank you so much, doctor, for your kind words. At the outset, I would like to thanks to the principal, Professor Datta Patil, sir, who invite me to share my views in national webinar on Ayurveda management of anorectal disorders. At the same time, I would like to convey to my regards to my seniors, Professor Sri sir, Professor Date sir, and all the seniors colleagues working in the Dhanvantari Ayurvedic. So, chairperson of this session, Dr. Manjusha madam, co-chairperson, Dr. Asmi madam, and coordinator, Dr. Vishnu Kant, and all the participants joined in this webinar. I would like all of you. Slide is hello.
Sir, slide is visible but not changed. Title slide is visible.
Only title slide. Now it is moving.
Yes, sir.
Yes, so I would like to welcome all the participants and delegates joined in this webinar on behalf of the Institute of Teaching and Research in Ayurveda, or Institute of National Importance, Jamnagar. So, what is the learning objective of this session? Introduction to the fistular nano, classification as per Ayurveda and modern point of view, then related investigations to confirm the diagnosis, management and treatment options available nowadays, then clinical evidences how complex fistula can be well managed with the help of Ayurveda, then concluding remark. Sir, it is clearly audible and visible also?
Yes, sir.
Okay. So, being an introduction, this slide shows that Bailey and Love's short practice of surgery has taken care of that Kshar Sutra, in which a specially prepared set on threads burst through the enclosed tissue. Why it has been taken care? So you have the potentials with the help of Kshara Sutra in the management of not only the fistula nano but also other anorectal disorders. And there are many publications in the public domain, so that the Bailey and Love had included in this international textbook that this is being done in the India, and this outpatient method has been shown to be equivalent to one-stage fistulotomy in patients with intrasphincteric and distal transsphincteric fistula. So at that place, he mentioned that only low anal fistula is being treated with the Char Sutra. But at the same time, what we are doing nowadays, we are also treating the complex fistula with the help of Char Sutra too. But again, there is need to have the publications in public domain. Then and then they will again encourage or included in the international books. So what definition is there? So Bhagandar, as per the Sushruta, he mentioned that Tetu Bhagandar Bhaga Buddha Basti Pradesh Dharanasya Bhagandara Ituchute Abhina Pidakaha Bhinastu Bhagandara. So what difference is modern fistula analysis says that there must be the two openings. One is the external opening and another one is the internal opening to the viscera or to the anal canal. But Sushruta mentioned that if there is a sinus also or any burst open pedica can be considered as the Bhagandara, though it has a single opening or a two openings. But if that is not separated, that is termed as the Bhinna Pidaka. Then coming to the what exactly pathology taken place in the fistuline anus. So more than 95% cases are origin from the cryptoglandular infection. So there are the crypts at dentate line, and that crypts get infected. It may be due to the trauma by hard stool. It may be infected. There is seepage of the stool, in the sense patient suffering from the ulcerative colitis or diarrhea, or it may be the bloodborne infection. So that crypts get infected and there is formation of the small abscess. Further, that abscess gets spread in the surrounding sphincters, particularly the intrasphincteric space, and through that it may comes out in the perianal skin. So it becomes the simple fistula. But unfortunately, if that fistula or that abscess is extended in the intrasphincteric and go above the levator ani, it becomes the complicated fistula. At the same time, it will be extended through the transsphincteric and goes to the istio-anal or istio-rectal space. Then again, it will become the complex fistula. So these two images show the complex fistula. But again, the origin of that fistula is at the dentate line, that is the cryptoglandular origin. According to Ayurveda classification, 5 classification has been made by the Sushruta, that is the Shataponaka, Ustragriva, Parisravi, Shambhuka, Unmargi. This classification has been made according to the etiological factor and what are the symptoms developed in that particular fistula, and there is an involvement of the dosic involvement. The concern of dosic involvement is that whenever we are treating the patients with medicine, it requires to look for the which variation of the dosage is there, and accordingly we can plan for the treatment. But nowadays also and in previous also, the fistulas are never treated with the help of medicines. It's required the surgical intervention. At the same time, Sushruta mentioned 3 additional fistula types or Bhagandar types, that is Parikshepi, Ruju or Arsha Bhagandar. It can be correlated in modern, that is Harsha fistula, straight fistula, or fistula with piles or piles fistula. In Chikisasthana, though I mentioned the types, but in Chikisasthana, he had mentioned the 2 another types, that is Avachina and Prachina. Yes, nowadays also we are observed when we are going to do the PR examination, some fistulas are not having internal opening and some fistulas are not having the external opening. As you see in the pathogenesis, if there is a abscess formation at the cryptoglandular that gets in the surrounding structure, particularly intrasphincteric, but it is not open to the exterior. That is termed as the fistuline or Bhagandar by Sushruta. So Bhagandara Samiksha Parachina Avachina Dua. You have to be identified is there is an external opening or internal opening. That is in modern blind internal, that is Avachin, it indicates the Antarmu. Here only internal opening is there and external opening is not there. And in blind external, that is can be correlated with the Parachi, that is the Bahirmukh. Only external opening is there, but there is no internal communication with the canal. And in this case, he has clearly mentioned that excision of the tract. Then Pranidhayam Ashanim Unnamam Sa Ashayam Udhareta Shastrena. So in such type of sinuses or Bhagandara, total excision has been mentioned by the Sushruta. Then Sharsutra application. Here Sharsutra should be applied. Rasha Dupal Luna Nadi Marma Srita Chayak Sharsutrena Amachindan Natu Shastrena Buddha. So in these patients, particularly those debilitated those are having cachexia, those are having afraid or scared to the surgeries, or the nadi or particularly the sinuses at murmur of this, that should be treated with the Kshara Sutra. And another fistulas can be treated with the surgery. And he has very clearly mentioned how to put the probe and how to go into the internal opening, and finally it should be Samaniyam Gadam Bandham Samacharya. So not too loose, not too tight Kshara Sutra should be applied in the fistula tract. So this is brief about the Ayurveda portion in relation to the fistula and now coming to the anal sphincter, it is very, very essential to understand the anatomy of the anal sphincter whenever we are treating the cases of the fistula in surgically. So here it is the internal sphincter, which is the continuation of the muscular part of the intestinal mucosa. Then this is the external sphincters, these three parts that indicates the superficial, subcutaneous, and this is the deep one, and this is the levator. Okay. So where abscesses has been taken place, particularly at the perianal region, that abscess burst open and open is the dentate line. Then second one is the ischiorectal abscess that opens in the perianal skin, and then it sometimes extends to the sphincter, external sphincter and intrasphincter. In the same way, intrasphincteric abscess, and another last one is the supralevator abscess. So these abscesses may be penetrate to the surrounding structures, and they communicate with the anal canal or sometimes in the rectum and even to the perianal skin. So this just in lithotomy position, how these sphincters are looped. That is the superficial sphincter. Then after that, that is deep, that's subcutaneous, and this is the deep one, and another that is the levator. In female, here that is the gluteus maximus muscle, this one. Then this is iliopsoas muscles, and then pubococcygeal muscles, and these are the external sphincters. In anterior, you have to be taken care when you are doing the surgery. That is superficial transverse perianal muscles that should not be damaged when we are going to perform the anterior fistulas, particularly in the female. I mean, classification of fistula in ano. What classification is being practiced nowadays, and what is the history of the classification? So first, oldest classification, that is Millie and Morgan classification, then Pass classification, then St. James University Hospital classification. Those are practicing the surgical in anorectal disease. In MRI, usually the radiologist mentioning the grade according to the St. James University Hospital classification. But nowadays, Dr. Pankaj Garg, who is the very known proctologist in Punjab, he had developed the classification, and this classification is also nowadays is being recognized and mentioned in the MRI. And last classification, Joban Putra's classification, is one of the practitioners in Gujarat, and he had developed some different classification. We will just have the knowledge of this classification so that it will be helpful to diagnose as well as to manage the cases of the fistula in ano. The Millian classification is based on the level of internal opening related to the anorectal ring. So this is the low level fistula. In this, what happens? The internal opening is the anal canal at the anorectal ring. That is the subcutaneous fistula, low anal fistula, and submucous fistula. Only simple classification he has mentioned on the basis of internal opening. Then high level fistula, that internal opening opens at the anal canal above or at the anorectal ring, above the dentate line, that mostly the lower rectum. So it is the high anal and cervilectal fistulas. So only simple classification has been mentioned by the Millie and Morgan. Then coming to the past classification, it is also being widely used, and it is based on the anatomy and specifically relation to the anal sphincter. So the intrasphincteric, as we learned about the sphincters, between both the sphincter, that is internal and external sphincter, when fistula penetrates through the intrasphincter and spares the external sphincter, that is called as the intrasphincteric fistula. Then transsphincteric, the fistula passes through the both, that is internal as well as external sphincters, that is transsphincteric. Then suprasphincteric, in the sense as you see in superficial and deep sphincter, above that sphincter if fistula is there, that is termed as the suprasphincteric fistula. And extrasphincteric fistula, that is, if you look into that image, it is not involved both the sphincters, that is external as well as intersphincter. They are directly communicate with the rectum and open in the gluteal region. So that is the extrasphincteric fistula. It is only in 5% cases. So most of the cases are included in the intersphincteric and transsphincteric fistulas. Very few, only 20% are the suprasphincteric. And again, it may be due to the other abdominal pathologies or abdominal disease conditions. Then University Hospital classification, it deals not only with the demonstration of the primary fistulous tract, but also with the secondary ramification associated abscess. See, it is very, very important to understand, is there having the different branches of that fistulous tract? Is there is having the fibrosed abscess, previously abscess, or abscess active abscess cavitation? Because if you are not address these conditions, the recurrence is more. And that's why St. James University Hospital classification is based on these different tracts as well as the abscesses, so that we can plan the surgical procedure according to that. So grade 1, when there is a intersphincteric fistula, see this one is only, it is a superficial and it is open at the dendritic line. Then intersphincteric fistula with horseshoe extension. Second grade, when there is an internal opening at the 6 o'clock, at that time it is right as well as left, both extension is there. In this end, only we see the in the right side only one fistula strand. In this, both extension is there, so it is the grade 2. As grade increases, the severity of the disease condition is. So intersphincteric fistula with intersphincteric is there, but there is abscess formation. Okay, so you need to have the special attention how to deal with that abscess during the surgery, and after surgery how it will be totally drained out. Then grade 4, transsphincteric fistula. In this, the sphincters, that is both external and intersphincters, are processed and open in the anal canal. So that is the transsphincteric fistula. Then grade 4, transsphincteric fistula with ischioanal abscess. It is a transsphincteric, but at abscess formation at the ischioanal or ischiorectal fossa is there. And grade 5, there is a supralevator extension. As you previously said, it is not crossing the external as well as intersphincter. That is directly open in the supralevator extension. So these are the classifications based on the extension of the tracts and formation of the ramification and abscess. Coming to the Pankaj classification, it is very, very important. If a surgeon is well aware of this extension and all these gradations, will be able to plan the surgery according to that. So there are again 4 grades. Grade 1, that this classification is based on the clinical practice and MRI diagnosis. It is first type of classification which have clinical data and also suggest about the surgery. So Dr. Pankaj Garg has the data of 848 operated cases, and the MRI assessed the anal fistula. So this is the study has been published in the reputed modern journal, and 848 is the good number of data to prove that yes, it is effective and which procedure is being done on the basis of MRI and this classification. So low linear, that is intersphincteric and transsphincteric fistula, as you previously seen. In this case, only external sphincter, that is 1/3 external sphincter is involved. Means only a superficial part of the external sphincter is involved. And in this, low linear intersphincteric and low linear transsphincteric. So you must be aware of these terms. Intersphincteric in the sense between the both the sphincters, trans in the sense it crosses the sphincters. And he mentioned only fistulotomy to leave open is possible in all points of the fistula, and it is having the success rate that more than 95%. See, this is the intersphincteric. If you look into the blue coloration, this is the internal sphincter, and this is the external sphincter, and this is the superficial part of the sphincter. So here that is external opening, and it is going to the intersphincter, and then it is communicating with the so in MRI, these are the just findings. We are not going into the details how it is looking. If you correlate with the MRI, then it is better, because MRI is set with the gold standard as far as the fistula is concerned. And this is the transsphincteric. So both the sphincters they crosses. This is the external sphincter and this is the internal sphincter. but it is again the grade 1. Then grade 2, here in grade 2 there are the 5 subgrades, but all these are considered in the grade 2. There is a low intrasphincteric and transsphincteric fistula, and again there is an involvement, it is less than 1/3. But in previously there is only single track. In this case, abscess may be there, multiple track may be there, horseshoe extension may be there, supralevator extension is there, and as well as supralevator extension with intersphincteric connections. So these are the 5 subgrades. If you look into that, this is involved the lower 1/3 sphincter, but there is abscess. Though it is involved the lower 1/3, but there are the multiple branches. In third one, there is a horseshoe fistula. In this lower sphincter is involved, but through intersphincteric extension goes towards the supralevator, and here it is supralevator as well as horseshoe. So these are all these are included in the second grade and having the different ramifications and the abscesses. So this is the second grade. And in second also, we have to be majority of the cases needs to the fissulotomy, and it is a successful treatment. But at the same time, we need to address all the branches as well as the abscess. In third grade, yes, it is the high linear transcript fistula. Now with the sphincter is more than 1/3 involvement. Look, if you look at this is the superficial, then subcutaneous, and this is the deep sphincter. So that fistula is crossing the deep sphincter, and then though it is open in the dentate line, but it crosses the deep sphincter. So whenever we are going to fissulectomy, there is damage of the deep sphincter too, and it is quite difficult practically to approach this deep sphincter. So fissulectomy should not be attempted. In this case, should not be done the fissulectomy. And another in third, fistula with cause disease and other abdominal conditions. It may be the malignancy, it may be the tuberculosis, it may be the cause disease, it may be the diverticulitis and all. So in this, he had mentioned the different methods as far as the modern is concerned. What we are doing in Ayurveda, we will discuss in the coming slides. But what they are advised, that is the FPR, that is fissulectomy with primary sphincter reconstruction. Then lift technique, that is ligation of intersphincteric fistula tract. Then WAFT, that is video assisted anal fistula treatment. Then AFP, that is anal fistula plug. There are the different methods. We are not going to detail. The fistula plug is there. We are put that plug over there, and there is no infection from that opening. But again, there is a cost is matter. It is well practiced in the Western and rich developed countries. But as far as the India is concerned, in metro cities, it is possible. But again, having the limitations in the form of recurrence. Then TROPIS, that is trianal opening of the intersphincteric space, and over the scope clip proctology, that is OTSP. So these are the innovative techniques and advanced techniques is being practiced in different by different proctologists in Western countries as well as India too. And this is needed in the grade 3rd of the Pankaj classification. Then 4, here again the complex or high anal fistula, and again the sphincter is more than 1/3, and there is abscess, multiple tracts, and horseshoe. In this case also fissulectomy should not be attempted. So here look, this is the abscess, then it is extension to the intersphincteric, it is going to the horseshoe extension, and again it is the intersphincteric, though the internal opening at the dentate line. Okay, so this is again the high sphincteric with multiple tracts. Here multiple tracts are there, and there is external opening at the perianal skin. We discuss, we have treated such type of cases. I will discuss in the next slides. So all these grade 3 and 4 should be treated with the different interventions or advanced techniques, and then it will be successfully managed. Again here grade, that is a transsphincteric with intersphincteric and supralevator. In this case, supralevator extension is there, and this supralevator extension, it may be through the intersphincteric, it may be through the extrasphincteric, and such type of fissulas are very, very complex, and it needs the integrated approach to whenever we are treating with the Kshara Sutra. Sometimes it may need the partial fissulectomy and then putting the Kshara Sutra, and at the same time to addressing the GIT problems, particularly the cause disease, ulcerative colitis or diverticulitis, and so on. So these are all these are the MRI guided fistula extension. And Dr. Jogalputra's classification, he had mentioned in the two fistulas, that is a simple fistula and complex fistula. When it is said to be the simple fistula, low anal, then usually single opening. There is no abscess or any cavity. There is no involvement of the any other organ, and abscess of the anorectal structures, and no any active rectal diseases in the sense proctitis, like. And the complex fistula, whenever a patient come to you, if it is a high level, and opening is above the anterior line, there may be the many or multiple openings externally. Then presence of the abscess or cavity connecting to other viscera, particularly rectovaginal, presence of the other anorectal strictures and active rectal diseases. So these are the classifications based when patients comes to you for the treatment. We have to be explained that your fistula is the complex one and it is need to long-term treatment, and it may be the having the recurrence 5 to 10% recurrence of this case because it is not the simple fistula. And when such type of fistulas are come, you can assure that you get 100% cure without any recurrence. So this is about the fistula by the different surgeons. Coming to the clinical diagnosis and investigations, most of the teachers and practitioners are very well aware of this, which is for just the PG and PhD students. When a patient comes to you, there is a very important to clinical assessment. What is your clinical findings when patients come to you, when you are taken the patient's clinic and doing the PR examination? Yes, obviously, external inspection is very important. What is there? Is there any change? Is there any abscess? Is there any external opening? Okay. And then go for the PRE, that is for rectal examination. Without xylocaine jelly or lubrication, do not put the finger, otherwise it will be too painful to the patient. And encourage the patients what you are going to do. Ask the patients, I am doing the PR examination, so patient will be cooperate with you. So per rectal examination should be done with the index finger. It may be as per the practice, left and right index finger. And after putting what were expected the findings, is the rectal temperature is normal? What is the status of the sphincter? How many internal openings are there? Okay. If internal openings are there, what is the status of that internal opening? Is this the fibrosis? Is this the broad one? Is there is the infected or internal extension is there? So if internal extension is there, intersphincteric extension, what is the status? Is this suppurated? Is this fibrosed? Okay. And at the same time, in male and female, you have to be observed for that. Prostate gland as well as the cervix in the female, is there any malignancy or any growth is there? Okay. And sacrum in the posteriorly. So all these findings should be noted properly and then go for the probing. If patient is cooperate, then and then probing should be done. Otherwise, probing should be done during the surgery, but you can put the probe to know up to what extent or what is the length of that tract. Then fistulogram. Yes, nowadays fistulogram is very rarely used in the practice of anorectal. I don't know, in some institute they are being used because there are the false results sometimes. If there is a seepage of some type that dye, radiopaque dye, sodium nitrate, then it will be having the false finding. So it is not correlate with your clinical finding, and that's why it is not being used. And also the one was that is the exposure of the radiations. And third one is so
Hello, sir, your voice is not audible.
Mostly. Hello.
Hello.
Is it okay?
Sir, it is breaking a little bit.
Hello.
Yes, now audible, sir.
Hello.
Yes, sir, audible.
No audible. No, there was a call. There was a phone call. Yes, okay. There was some little bit disturbance. Anyway, so fistulogram, and nowadays what widely used, that is the TRUS. It is termed as the transrectal ultrasonography. In our institute, whenever we are doing any kind of research, our main objective is to translate that knowledge. That knowledge may be spread throughout not only the India but abroad too. And then that's why we are giving the topic. One scholar has given the topic that you need to assess whatsoever the fistula with the transrectal ultrasonography. So he had treated 30, 60 cases, and in almost 20 cases, we have done the transrectal ultrasonography, which is having the multiple branches. So before treatment, we did the transrectal ultrasonography, and after treatment, we did. So if there is a fibrosis, the radiologist mentioned that there is a fibrosis or that is the tract. Okay. So how many times that fibrosis will be resolved or become the normal tissue? That was the main objective of this study. And it was found that almost it's required more than 3 months. We have the normal tissue. Otherwise, if you do after just healing of that tract, the radiologist show that there is a tract. So but that tract is nothing but it is the fibrosis. It is not the active tract. So the truss is the best one because it is economical, almost different places different, but in our places they are taking 500 to 700. And as I told you, the MRI, yes, MRI is the gold standard because in this we have all the extensions up to the supralevator, how many ramifications are there, what exactly the length of that tract, or what are the abscess cavity, how much dimensions of that abscess cavity, and each and everything. But it is not affordable to each and every patients being a developing country of India. So trust is the best one as far as our experience is concerned. But in some selected cases, if you suspected that there is a fistula in the supralevator extension, it is mandatory or we have to encourage to the patients to go for the MRI. So on the basis of this clinical assessment and on the basis of these investigations, we can diagnose the case of fistula and you can plan the appropriate surgery. Other blood investigations according to the general condition of the patient is needed. We are not going to discuss at that point. Then what is the principle? What principle should be adopted? See, when patients comes to us with a pus or particularly the active abscess, yes, it is mentioned in the classics also, and nowadays it is as early as though it is the abscess in the sense fluctuation is there and not. You have to be need to do the IND and drain out all the pus, and after that, appropriate antibiotics is needed if patients having the fever and counts are increased. But for the prophylactic, we can prescribe accordingly. But it is very, very essential to control the sepsis when patients come in the sepsis condition, though it is having the other fistula or other disease condition. At the same time, it is very, very essential to drain the perineal abscess as soon as possible. Then define anatomy. As I told you, it is very, very essential to know the sphincter, then intersphincteric spaces, perineal spaces, and opening and tracts. How many internal openings are there? How many external openings are there? It should be noted. Is the single opening is there or multiple openings are there? What are the extensions? Is there is a simple intersphincteric extension? There is a horseshoe extension or supralevator extension? And the relation to the sphincter, is it is a low anal or it is the high anal? It is very, very essential and we can understand how experienced we have to understand what sphincter is involved in that fistula. And definitely when you are discussing with the patient, the prognosis, as far as the prognosis is concerned, if patient is suffering from the cause disease or cervicolitis or diverticulitis or abdominal cause or any abdominal condition, simply IBS, you have to be confirmed that you are not treating that condition. That's why you have to be assessed systematically if patient suffering from any other abdominal condition. Nowadays, in Western countries, there is a mandatory when you are treating any anorectal disorder, it is mandatory to go up to the sigmoidoscope. Until and unless you are not going to sigmoidoscope, you are not confirm that what pathology is in the particular sigmoid colon or particular large intestine. And we are also practicing in such type of conditions. If you are suspected, there is ulcerative colitis, you have to be need to go for the colonoscopy in cases to confirm that ulcerative colitis is up to what extent. Is it only involve the rectum, is only involve the sigmoid colon or descending colon, transverse colon also. So it is very, very essential to assess and we have to be convinced the patient accordingly. Then treatment plan. Yes, as I told you, there are the level of surgical risk will depend on the location of the fistula and the specific procedure chosen for the treatment. Whenever we are choosing any procedure, we must know what are the exactly prognosis or what is the expected outcome or unexpected hazards or complications. And then we can say okay, this patient or this fistula is taken more than 6 weeks, more than 8 weeks, and so on. So the surgical options are available: fistulotomy, fistulectomy. Yes, according to the need, according to the practice, according to the experience. If it is the subcutaneous, low anal, only superficial sphincter is involved, that is the best one and best treatment. No need to put the Char Sutra even. But if patient insists, okay, I am come to you for the Char Sutra, just open and then put the Char Sutra in there. But in low anal, it is the best treatment. Then set-on techniques. Yes, in modern practice, they are putting the set-on of different materials. Then advancement flap procedures, lift techniques. I'm not going in the detail. Ligation of interspecific fistulous tract. Then endoscopic ablation. There are nowadays laser surgery very much popular in the private practice. Yes, you can do. Then fiber glue, that is fistula plug, and bioprosthetics plugs. Different plugs are there. So these are the surgical options available according to the what is the extension, what is the ramifications, what kind of fistula is there, and which sphincters are involved according to what we do, what Ayurveda surgeons can do in such type of fistulas or complex fistulas. Yes, the Char Sutra application is the best one. If track is small, though it is an intrasputary, though it is a transfiltrate, you can put the Char Sutra, and regularly we can change with the techniques. And almost if it is the 4 centimeter fistula, it's required the one job regularly. That partial fistulotomy and Char Sutra. We have innovated hello. Hello.
You are audible, sir.
Audible, no? Okay, okay.
Yes.
So partial fistulectomy and Char Sutra. In the sense, if tract is having more than 10 centimeter and 9 centimeter, then we need to go for the partial fistulectomy or lay open accordingly. And in the remaining tract, when sphincters are come, when instance sphincters are come, we can put the for 2 to 3 centimeter Char Sutra. So that is the best. Why that is the best? So at the same time that fistulectomy wound will be healed, and at the same time that fistulous tract is also cutting and healing takes place with the help of changing the Char Sutra. So we can save the time of that patient. That is the very, very important thing. And then 2-stage integrated approach with the Char Sutra. We are practicing because being our center as a tertiary care, most of the surgeons are referring the complex fistula directly to me or in our hospitals. And at the same time, civil hospital, there is a GG hospital or government medical college in front of the hospital. So they are also referring all the fistulous cases to us. So the cases which are having the multiple tracts, initially we put the Char Sutra, okay, and we change for 3 to 4 or 5 accordingly. And when posterior all the drainage has been taken place, then we laid it open. That fistulous tract is going to laid it open in the next stage. In the sense, after 1.5 months, we are doing the 2 times procedures, convincing the patients. And this is the 2-stage integrated approach with Char Sutra. We will discuss the case, then it will be more clear. And lift tract technique, Professor Sahu sir has been innovated this technique, that is intersection of fistulous tract and application of the Char Sutra. Yes, as you see in the grade 4 and grade 5th of the Pankaj Gus classification, we can use this technique. And as far as my experience is concerned, some cases having the recurrences. It may be due to the patient side, it may be due to the technique, but some cases having the recurrence, and we are also practicing these techniques. And then what are the complications we are expecting? Yes, sometimes the infection, local infection as well as sometimes the systemic infection, we need to control with the appropriate measures. Then recurrence of the fistula. As I told you, whenever I taking the written consent of the patient, it is very essential to explain each and everything. How many percentage chances of the recurrence are there. Then patient will mentally prepared. Yes, at the time of surgery, a surgeon has been already explained the things. So yes, in some cases recurrence are there. You can't say with the Char Sutra there is no recurrence. So don't do the bold statements. In complex fistula, yes, it is obvious. But again, if recurrence is there, we can treat that cases. And bowel incontinence, when we are going to exercise the extension up to the liver, then bowel incontinence is there. Otherwise, if you cut the deep sphincter even, there is no incontinence. Only sometimes flatus incontinence is there, but bowel incontinence is very rare. When levator ani above that damage of the sphincter is there, then it will be the bowel incontinence. I'm not going in the detail. Everyone is very well aware of that. That Char Sutra is a medicated thread made of linen barber 20 and 14 suspect syrup, amarkshara and turmeric powder. Yes, Chakradatta has mentioned that Bhavitam Rajis Vesmikshri Punapuna, and it has been added the Kshara. So if Apamarga 100 kg Apamarga has been burnt, it will get the 10 kg of the ash, and with the 10 kg of the ash, we will get the 1 kg of the Kshara, and Kshara is being used for the Char Sutra preparation, and sterilization has been taken care. Char Sutra cabinet and all these techniques is being used for the aseptic precautions of the Char. Then coming portion, that is clinical evidences. See, as per the Ayurveda, it is said to be the Shatakonaka Bhagandar. As I told you, whenever we are treating the medicine with the medicines, then that matters the involvement of the dosha. But when we are going to do the surgery, but for the sake of knowledge, yes, it is mentioned by the Sushruta. Multiple openings are there. Patients is the 47-year male, and it is not the adenitis. The history of the multiple boils was discharged since last 2 years. So in this case, if initially we put just the Kshara Sutra, and then it will be drained out some part of that, and then we patient after resolution of the infection, patient taken for the surgical intervention, remove all the tracts that are interconnected, but these are the superficials, so there is not a issue to have the more damage of the sphincters or damage of the tissue. And in sphincter, we have put the Kshara Sutra. Subsequently, in 2 weeks, the wound has become clean. At the same time, we are using mostly we are trying to use all the Ayurveda medications, being a research institute or in our institute. So all the medicaments, Panchavalkal Kashaya or Tripura Kashaya is being used for the cleansing purpose, and for the dressing purpose, different ointment, Jatyadi Grath, Katupila Tel or Katupila Grath, Estimadu Grath is being used for the. As this wound becomes clean, then it is subsequently having on the 4th week, it is a good contraction. Ultimately, almost it is in the healing stage. And in 9th week, it is completely healed, and also that fistula has been cut through. At the same time, being mandatory, or it is essential to know how that is being published in the Annals of Ayurveda Medicines. It is needed to publish the data in the reputed journals, so everyone can assess this case, what exactly has been done, and he or she can be practicing their practice if such type of patients they are came across. This is the as you see the yellow colored set on. This is the young engineer, 32 years, working in the Reliance refinery, and he transferred from Chennai. He was operated in good surgical hospital in Chennai and put the set on. If you look into that, he said that he had having the IND from here upstairs, and the Char Sutra has been put through that 6 o'clock position. When again we are go for the truss, it was found that there is a fibrosing changes. Okay. And we'll explain each and everything to the patient about the recurrence and everything. And when you put the dye comes out from that. So there is definitely, though there is an intrasphincteric or it is at the dentate line opening, it is having the extension. Okay. So this is the extension that is need to the address. So in this case, we do the partial fisturectomy. At the same time, there is also extension towards the 7 o'clock. Okay. So all these things has been addressed with the excision of and lay open, and simultaneously it is that Char Sutra has been put. 2 Char Sutras. One is at through that opening to 6 o'clock, and another one 6 to 6 o'clock. And simultaneously that changes and dressing has been done, and it was completely healed the patient within 10 minutes. When patients come to us, he said that I want to suicide. I'm very much harassed with this pain and all this set on, and patients go with the happy mood. Yes, we can treat such type of complex fistula too, and it is published in the reputed journal, European Journal of Medical Case Reports in the Western Science. So this is the one of the different case treated successfully with the integrated approach and strategy. And another case, that is 60 years old male patient, 6 centimeter long and two subcutaneous external opening. So see, it is feeling that there is an extension. So it is up to the left side of the scrotal extension and internal opening at the dentate line. So just lay open, remove all the tract from the base, ensure that there is no any part is remain, and then suturing has been done. Skin suturing, subcutaneous suturing, and then skin suturing, and in remaining tracts, Shar Sutra has been placed. So that is the terms as the primary closure, and then subsequently that wound is getting healed, and the tract has been cut through. And on the 6th week, see there is no any scar, and patient successfully managed, and it is also published in the journal. So different patients, we can have the different treatment options. This is again the one high. See, there is an external opening, and this is extra sphincteric. It is not involved in the intersphincteric, but when it is open at the 6 o'clock, there is having the extensions at 5 o'clock too, and intersphincteric extension too. So we lay open this, okay, in first stage. Then put the Shar Sutra with the extension in this, and in second stage we lay open this remaining portion. Okay. So previously this has been clean the abscess cavity and whatsoever the extension, and in second stage, as that portion has been healed, then it is easy to treat or address this portion, and subsequently that patient has been completely healed with integrated approach or two-stage approach within 12 weeks of treatment. And this is published in the Journal of Ayurveda case reports. This was one of the interesting case, 25 years female patients. She had consulted with 2 to 3 proctologists or general surgeons, and they refused to go for the surgery. Because if you look into that, in that image, this is one external opening, this is another one, this is another one, and this is one. Means it is the horse show as well as multiple openings. And this is the young lady. If you look for me, this is the truss. Okay. If you look into that, this is one opening, this is another opening, this is third, and this is fourth one. And all these are communicated at the 6 o'clock. And one extension is also there. So if you look into that view, so this is the external openings at the open at the perineal skin. This is 2 openings, and both the openings are going. This is the external sphincter, then internal sphincter, and then communicate to the dentate line. Okay. So in this case, if you extend total tract, again it is difficult, or sometimes maybe septicemia, and it will not maintaining the tissue structure at that place. Sometimes incontinence too. So we initially just lay open at that opening and put the Shar Sutra in each and every. Mostly these having extension opening at that 6 o'clock, making the window. Here we are make the window. Then put the Shar Sutra to external, then external to that window, then external to external, and then a window to 6 o'clock. Okay. So mostly 5 to 6 Shar Sutras have been placed. And after 4, 5 weeks, if you look, this is the one Shar Sutra, this is another one, this is one, this one, and we then lay open, because what happens posteriorly, that Shar Sutra, all these remove the debris, and as well as the healing will be takes place. So after cut through of that, see this structure. This is done in the second stage, and this is main culprit that you can say that the cryptocollator will put the Shar Sutra, and subsequently then this Shar Sutra has been cut through, and this is the last image of that patient, and she has been successfully treated without any recurrence and without any complication. Since last 3 years, she had not having any kind of complications. So this is the beauty of, we can say, Shara Sutra, but it is need to add some intervention which has been done in the model. It is not like that I have treated only with the Shara Sutra. Yes, Sushruta mentioned we can have the Chedan, we can do the excision. So why you are going to hesitate? Yes, it is needed to have such type of complicated cases should be treated with the integrated approach. Then and then we will be getting the success. We are using the Shara Sutra and Chedan procedure in this case. Coming to the concluding remarks, yes, Shara Sutra is a better option in fistula, in ano, all kinds of, I would like to say, due to minimal invasive procedure, ambulatory treatment, it is need to encourage the patient, because when patients have the collection in the fistula tract, at that time patient having the same pain when you put the Char Sutra. So encourage the patient to ambulate. Less recurrences. I am not claiming no recurrence, because yes, some cases 1 to 5% cases recurrence is there, but in modern they have reported that 5 to 20% recurrences. So there is a less recurrences, no incontinence. Yes, you can say that. Early recovery, obviously. Cost effective, yes, it is. If you use the fistula plague, it takes the more than 80,000 and 1 lakhs, and less post-operative complications. So these are the beauties of the Char Sutra, and that's why it is needed to apply in all kinds of fistula. The Char Sutra therapy is well established and practiced not only in the India but also in the Japan. The name is the Kana Java Sutra. Not only simple fistula but complex fistula can be well managed with integrated approach with positive outcomes. As far as the research point of view, there is need to standardize the treatment protocols according to the types of fistula, and these protocols randomized control trials need to be published in the journals so that everybody can take this advantage or look into that and practice in their own places. And Char Sutra is having upper hands in surgery as Panchakarma in the medicine. So keep practicing and keep publishing the data in the public domain. So our Ayurveda can be flourish in the name of Char Sutra in more and more in the coming days. So with this, I would like to thanks the whole organizer, all the organizing teams, and the chairperson, co-chairperson, and all the listeners, students, dear PG and PhD students and practitioners, and dear faculties for patience listening. Thank you. Thank you.
Thank you, Dr. Tukaram Dudmal sir, for such a wonderful and informative speech on role of Ayurveda in diagnosis and management of fistula in ano. This speech will surely increase our knowledge and will give updates about management of fistula with Char Sutra. Dr. Dudmal sir very nicely explained details about fistula in ano and its management. Now I request Dr. Manjusha Kalmek Madam to comment on this lecture. Dr. Manjusha Kalmek Madam.
May I audible?
Yes, madam, you are audible.
Good afternoon, everybody. First of all, congratulations for organizing such a national webinar on anorectal diseases. Thank you to Dr. Datta Patil sir, Dean and team of Dhanvantari Ayurved College, Latur. Thank you for giving me opportunity as a chairperson of this session. Congratulations, Dr. Tukaram Dudmal sir, for giving lecture on such a complicated topic according to Ayurveda as well as modern science. This topic is very difficult to treat and very difficult to study also. But Dr. Dudmal has made this topic very easy by giving knowledge about modern and old Ayurvedic treatment through this lecture. So this very nice and very studyful lecture by Dr. Dudmal. Congratulations, congratulations again the organizing team, and best wishes for future. Thank you very much.
Thank you, madam.
Thank you, madam. Now I request Dr. Rashmi Kale Madam for comment on this speech.
Good afternoon, everyone. Am I audible to all of you?
Yes.
Yes, madam.
So again, good afternoon to everyone. I'm really fortunate to be a co-chairman of this session. It was a very nice presentation by Dr. Dudmal sir. After a long period, I have gone through the detailed theory with clinical discussions of few interesting cases. It was really interesting cases. In practices, we are also preferring integrated approach to high anal fistulas. And as we all are very aware and proud of this Char Sutra therapy in Ayurveda field, it is really wonderful and is able to release Char in all pockets and ramifications lead to the One first is it is having hygroscopic in nature, where we can like pus and other discharge can be removed by this hygroscopic nature of Shar. Then there will be there is a scrapping action where fibrous tract present. This Shar, like it lechan, we say the lechan activity of scrapping activity of Shar also increase blood flow and leads to the healing. It's really very helpful in fistular nano. This integrated approach we are preferring nowadays also reduces the time period, and sometimes patients are having allergy to reaction to Shar Sutra, so that can be avoided. And integrated approach again in these cases, Sir Dudmal sir, I would like to add one thing, that we prefer that lift with Shar Sutra. So the lift with Shar Sutra is also giving very wonderful results. And again, the second thing what you are saying, that integrated approach and, with Shar Sutra and the interceptive physiolectomy or physiotomy, both. That is also again we are using in practices, which are really helping us in complicated fistulas also. I'm really thankful to all of you, all organizers, Principal Dr. Datta Patil sir, and all the Shalya Tantra department for giving me opportunity for sessioning this as a co-chair. And it was really wonderful presentation by Dr. Dudmal sir. Nice to meet you and see you on this in this webinar. Thank you very much.
Thank you, madam. Thank you.
Thank you, Dr. Rashmi Kale, madam, for a wonderful comment. Now I request from audience, if anyone wants some question, you can ask. We have only 5 minutes. Sir, one question. Dr. Dudmal sir, one question. Is there any contraindication in using Kshar Sutra in fistula? That we should not use Kshar Sutra in that case?
No. Actually, contraindication is not there. For example, if a fistula is there and there is a big abscess, so in such circumstances, there is need to take care of the abscess. If you simply put the Kshar Sutra and posteriorly if abscess cavity is there, so in such circumstances there is again the recurrence. What happens usually, if you not go for the investigations, particularly the TRUS or MRI, and clinically if you find simply the tract, then what we are doing, newcomers are doing, it is not frequently happen, but sometimes happen. So we are directly probing, and in that probe we put the Kshar Sutra. But above that there is an extension of the abscess. Okay, that abscess may be resolved, and that's why it is not being addressed at that time. Then there is the recurrences. But as such, there is not a contraindication of the Kshar Sutra. Another thing, if it is the what we can say absolute contraindication, if it is the supralevator extension, don't touch such type of fistulas, because that fistulas are never complete curable, and these fistulas are due to mostly the other abdominal conditions. So if MRI report shows that there is a supralevator extension, if it is the below the levator, then it can be drained out with the Kshar Sutra and some releasing that tract. But if it is the supralevator extension, then such type of fistula, Kshar Sutra is not beneficial.
Okay, thank you, sir. Now I would like to invite a comment from Dr. R.R. Sharma, observer from MUHS Nasik. Dr. R.R. Sharma, sir, please comment.
Good afternoon, all of you. Many thanks to all speakers, organizers, chairperson, coordinators. Especially thanks to Dr. Datta Patil sir. Speakers delivered very nice lecture about Earth's fissure disease. After Udar Chikitsa, Acharya Charak described Earth. That means if Udar is proper, no urge can develop. In Sushrut, after Vat Vyadhi, describe urge. Arivat प्राणान श्रीनाति इति अर्थ, अर्थात अरि कहा है आर्य को. आई एम ऑडिबल सर?
Yes, audible, sir. You are audible, sir. Yes.
अरिवत प्राणान श्रृणाति इति अर्थ, अर्थात अरि मीन्स आरा, लकड़ी काटते हैं जिससे, उसके उस तरह से प्राण का क्षरण करता है अर्श व्याधि. इसके लिए आपके टू स्पीकर्स, डॉक्टर भाविस्कर एंड डॉक्टर तुकाराम दुधमल sir, both are delivered best, nice, valuable and knowledgeable lecture. I observed some technical error, but they are negligible. I also thankful to Udgir Management and Institute who gave me this type of observations and very nice full lecture. Again, I am many congratulates you. Thank you.
Thank you, Dr. Sharma sir. Once again, thank you, Dr. Tukaram Dudmal sir, Dr. Manjusha Kalmeg madam, and Dr. Rashmi Kale madam for this session. Now we are concluding our webinar, today's webinar. I request Dr. Yogesh Surnar sir to give vote of thanks.
Good afternoon, everyone. I am here to present vote of thanks. I would like to thank our chairperson, Honorable Dr. Sanjeev Yadav sir, Honorable Dr. Manjusha Kalmeg ma'am, Honorable Dr. Kalpana Pandre ma'am, and my respected PG teacher and HOD, Honorable Dr. Kai ma'am. Thanks to sir and ma'am for joining us. I would like to special thanks our eminent speaker, Honorable Dr. Tukaram Dudmal sir and Honorable Dr. Rahul Baviskar sir. I am sure that the precise knowledge that Dr. Tukaram Dudmal sir and Dr. Rahul Baviskar sir gave us will definitely help us in our study and practice. I would like to thank Dr. R.R. Sharma sir. Also, thanks to our principal, Dr. Datta Patel sir, for giving permission to organize this national webinar. Also, I thanks to all participants, students, practitioners, present here for paying attention and learning. Special thanks to Dr. Avinash Jadhav sir and organizing committee members, Dr. Namdev Bansode sir, Dr. Om Chitte sir, Dr. Namrata Kore ma'am, Dr. Vishnukant Jadhav sir, for helping us in this webinar. Thank you. Thank you so much to all.
Thank you all of you. Now we are closing the session. Thank you once again.
A small announcement for the participants. All the delegates are requested to fill the feedback form, and after filling the feedback form, you will get the email regarding the certificate after 15 days. After 15 days, the certificates will be dispatched in the batches. Thank you. Without filling the feedback form, there will not be any certificate. So I request all the participants to fill the feedback form. After feedback form filling, the certificates will be automatically generated after 15 days. Thank you very much.
Thank you.